Good morning, everyone. We'll go ahead and get settled down. Today's speaker is Dr. Anita Jeyakumar. She is the Director of the Pediatric Cochlear Implant Program and the Section Chief of Pediatric Otolaryngology at Carilion. She's been here for almost a year in August. She comes from medical school at Meharry, her residency at University of Rochester, and a fellowship training at Cleveland Clinic Foundation. She is a widely published author and national speaker, and we are thrilled to have her here today to discuss pediatric airway basics and management today. Please welcome Dr. Anita Jeyakumar.
All right. So this is a very, very interactive talk, which really means I'm going to be asking at least the residents a lot of questions. So where are the residents? Just show of hands. This whole area here, sort of. Okay. So here are how the rules of the game are. I'm going to ask lots of questions. There's no wrong answers. I'm going to ask you to kind of verbalize. Can you all hear me, by the way? I'm going to ask you to verbalize some of your thought processes. It's sort of like I'm thinking this and you're thinking that, so we can talk it through. I really walked the line here of trying to say, okay, what's basic for me and what's overwhelming for you guys, and hopefully we found a balance. So I don't have any disclosures. The way I decided to focus our talk is we're going to talk a little bit about anatomy. Obviously, I'm a surgeon, so anatomy is really, really important to what I do, and certainly, hopefully, will translate into what you do. The focus of the talk is going to be what I call horses and zebras. So what does that mean? So as I talk about airway anatomy, when we think about airway anatomy, oftentimes there's a group that thinks of airway as just lungs, and then there's a group of things of airway as just nose. Well, the airway is all of it. So as we're talking about the different parts of the airway and we go through, it's important to understand that when we're seeing a patient, the patient might be a horse or they might be a zebra. Horses are much more common, but we've got to think about the zebras on our list because certainly here, they're going to happen. And if you don't think about the zebras, you'll miss the zebras. But the horse is by far most common. For purposes of this talk, the horse that I'm not going to talk about is viral etiology. So for almost every section of the airway, viruses are in the differential. But to start talking about viruses to you guys, I thought would be a disservice. So just keep in mind, as I show slides and pictures, viruses are #1 on the differential of almost everything I talk about, almost, but a few things with exceptions. We'll talk about basic airway management, like if a child is in trouble, what sort of algorithm do you want to have in your head as to how to tackle this child? We're going to talk about trachs. Everyone kind of fears trachs, and I'm hoping that with time we won't do that. You have to be, you have to have respect for trachs, but you don't have to fear them. And I'm hoping I can convey that. And then we'll talk about some troubleshooting and then a few more zebras to end the talk. So it's a lot of stuff to cover. I'll talk fast. If you have questions, just raise your hand. And like I said, I'm going to ask you guys questions. So like I said, the anatomy of the airway, this is the upper airway. So you look at the nasal cavity. It connects in the back to the nasopharynx. The oral cavity, which connects in the back to the oropharynx, which leads to the hypopharynx and the larynx. And then below that is the trachea. When you look at the airway, sometimes as we know it, this is basically the larynx. So this is the epiglottis. In the cross-section view, the false chords and the true chords are here, which then leads to the subglottis, which is very, very important in neonates in particular and kids, and that leads to the trachea. So if you want to take a gander and kind of feel at your own neck, when you feel way up here, you should feel a bone. That is your hyoid bone. So below that, particularly for guys, for adult guys, this is really easy. You'll have your Adam's apple, which is your thyroid cartilage. And then below that, you'll feel a ring. That's your cricoid. And below that are your tracheal rings. Now, I say this because this is also an adult male. These landmarks are not readily palpable in particularly babies because the hyoid cartilage is often cartilage. The hyoid bone is often cartilage in babies. And so this will lead into some of the things I'll talk about later as to why emergent airway management in children is different, because emergent airway management is all based on knowing anatomy. And if you can't feel the anatomy, you have to have a slightly different algorithm as to how you do emergent airway management. So it's a little bit dark, but what I wanted to show are we often are called to do fiber optic scopes, meaning we use a little fiber optic scope. It goes through the nose, and we can look at the upper airway. Do it a lot. It is not comfortable, but it is not painful either. So, and I qualify that because we're sometimes asked, just scope the kid. We're not really worried, just scope the kid. Well, it's important to know that it is not comfortable. How do I know this? I teach residents on me, not just any residents, so don't come after me. I do teach anyone going into otolaryngology on me because when my generation, I learned on patients and I didn't think that that was correct. So I know exactly what it feels like. Kristen here has had a few scopes done just for practice, and she knows what it feels like. So it's not necessarily comfortable, but it's not painful, but there is definitely a purpose to it. So what we do is we pass a scope. This is a scope going into the right nostril. The septum is here. This is the lateral nasal wall, and this is the inferior turbinate. We have 3 turbinates in our nose, which look like bumps on the outer nasal wall. We typically want the scope to go in a hole. So this is very similar in some ways to passing an NG tube, except it's not blind. So an NG tube, it's all based on the principle of resistance, right? You pass an NG tube, it bumps something, hurts the patient, and then it goes somewhere else. Well, here, I'm able to see where I'm going, so ideally, I'm not going to bump into it. You follow the hole and you follow the cave. As I'm traveling under the inferior turbinate, that is the nasopharynx in the distance. This is actually a view of the palate, so, and then this is the view of the nasopharynx. And here, this person's had an adenoidectomy, but if they had an adenoid, this is where I would see the adenoid. I then kind of drop over the palate, and I'm able to see the base of tongue, the epiglottis. What you'll notice is that my view is sort of an upside-down view. So the epiglottis is anterior in a patient, but usually me and anesthesia differ. So when anesthesia scopes the patient, they scope with the head and the face pointing that way. So everything is anatomically oriented. When I scope, the patient is facing me this way, so everything is backwards. And the reason why that's important is that this is the left side of the patient. So when I'm scoping, always kind of, especially if I'm scoping to say, is a cord out or whatever, I'm always having that internal dialogue, okay, left, left. It's almost like a handshake, you know, right and left, okay? So that's how I know where I'm oriented. So, but that's the epiglottis. These are the arytenoids. You cannot really see the cords in this picture, and usually you'll have to go closer. So can bad things happen when I scope a patient? As with any intervention, bad things can always happen. So technically, if I touch the larynx, these patients are usually not anesthetized. They're wide awake, so I can make them go into laryngospasm. So, and that's in my office, obviously not a good thing. So, you know, you have to be careful. I'm usually often hovering above and kind of moving out and in a little bit because usually, particularly for a baby, their glottis and their larynx is right there. It's at the level of the soft palate or really sometimes below. This is why when you look in their mouth and they stick out their tongue, sometimes you can see their epiglottis shoot up. That's normal in babies because everything is a little bit higher. And we'll come to that again. Now, this is a closer look at the glottis. So again, upside down view. So this is epiglottis. This is the left cord, right cord, arytenoids. And you can see that I'm not really looking at the esophagus too much. So I usually partner with our GI folks a lot to do an esophageal assessment. And in PEDS world, that's very, very common. There's a lot of partnerships that happen. I work with Palm, I work with GI. We all sometimes work together, and we just work together to put our collective brain cells for the better of the patient. This is a nice little bit of a clearer picture, and what you'll notice here is that this is an anatomically correct picture. So the epiglottis is in front. This is the right cord. This is the left cord. These are the arytenoids. And this is the larynx in adduction, meaning the cords come together. And the way I remember adduction, abduction is when you're adding, the cords come together. So, and then the other one is the other one. So anyway, so that's how I remember it. So this is adduction when everything's together, and this is abduction. And so that's how we breathe. So our cords open for us to inhale, and our cords intermittently close as we vocalize and exhale. And the reason why typically breathing is quiet is that when they open to inhale, the airflow is very smooth. Any turbulence created in airflow is noise. So turbulence up here creates noise, turbulence here creates noise. And those noises are interpreted differently, and we do different things depending on the noise. And there's a lot of gray here, as I'm hoping I'll get through, but there's also some principles we want to kind of keep in mind. So anyone take a gander about the differences between pediatric and adult airways? I've kind of alluded to some of them, and this is for you guys. So feel free to jump in. Let's see.
Larger tongue.
Larger tongue, that's correct. Why is that relevant? Why is that relevant? And how can it occlude the airway? By going back. So what do babies do a lot? They sleep, right? And they typically sleep on their backs. So if their tongue doesn't have as much room, or their tongue has any kind of pathology, what will their tongue tend to do to their airway? It'll obstruct. And obstruction is bad, right? Because that means someone's not breathing. What else?
Size of the airway.
What about the size of the airway, though? That's true.
That'd be a severe, like you talked about, the cartilage versus the more mature.
Absolutely, absolutely. So in general, those are all correct. So the size is obviously smaller. We wouldn't expect a baby to have an adult-sized airway, right? So a lot of those principles come into how we take care of our baby's airway, and we'll have some slides on that as far as the size and why even the tiniest of edema, a cold that we do well with, we may not function great, but we breathe well with, can tip a baby from doing well to not doing well and to not thriving. So in general, when we talk about the infant versus adult airway, so newborns in particular are obligate nasal breathers. What does that mean to you? Right, so when a baby's born, they're suddenly having to thrive in oxygen, right? Because that was all placental flow before. So when they're suddenly in the air, they have to use their nose, and they don't know how to breathe any other way. So they're typically obligate nasal breathers. So that means any pathology that affects their nose will affect that baby's ability to thrive. And any pathology that affects their nose will affect the baby's ability to feed. So those are really important to know. And their noses are small, so it doesn't take a lot for them to have an effect. The tongue is relatively large, we talked about that. The epiglottis is typically more omega-shaped and floppy, and that's not even if they have pathology, that's just baseline. That's why sometimes adult people will struggle to intubate a pediatric patient because everything is much more floppy and it's much more in the way. It doesn't just open wide open like a cave like it would in adults. The larynx is higher in the neck, and we talked about how this is why when they open their mouth, sometimes you can see the top of the larynx, you can see the epiglottis. The vocal cords are more anteriorly, necks are shorter. Kids tend not to have most kids tend not to have very long necks. And then this is probably one of the most important things. The narrowest part of a pediatric airway, as it pertains to the glottis and below, is actually the cricoid. Anyone know where the narrowest part of an adult airway is? The cords, that's right. So that's really, really relevant, and that goes into a lot of the debate that you guys will hear. Should we use a cuffed tube? Should we use an uncuffed tube? When do you push? When do you not push? I don't know that we know the answers to those questions, but in general, what I say is if you're trying to intubate a baby and you're meeting resistance, but you can see your cords and you can see that your tube is going through, drop a half size smaller. Because it doesn't take a lot, and that cricoid, you can't really see it well because it's under the cords, right? But that's the narrowest part in a baby. And so if there's trauma there, they will immediately develop issues there. Now, a lot of you, the guys who are, and ladies who are beyond your first year, helped me manage a kid last year. Do you remember this kid? He was born at 30 weeks, had been intubated one day, with an appropriate size tube and developed subglottic stenosis. And I had to take him to the OR multiple times, remember? And he really, really struggled, and hopefully so it doesn't take a lot. And so it's really important that from our ends, we minimize whatever we do because, again, there's a lot of gray in what we do. So when we're talking about horses versus zebras, so we're going to talk about the nose. Beyond viruses, any idea what the horse in a newborn might be in the nose? Any takers? Heard a hiccup. What's that? Is that a horse or a zebra? For you to jump ahead. Mucus, yes. So the most common cause of neonatal nasal obstruction is actually idiopathic. Their noses are just stuffy, but it's the most common cause. But again, why is that relevant? Because they're obligate nasal breathers. So if a baby has a stuffy nose, they're not going to breathe well, which means they're not going to feed well, which means they're not going to thrive. So a baby will drop off their curve from idiopathic neonatal rhinitis. Anyone know how to manage that? Suction, what else?
Time.
Time, absolutely. Time's always your friend, unless you're not thriving, then that's a problem. What else? Saline, right. So those are really the textbook. I know, doesn't that sound weird? A baby is potentially not thriving and you put drops and suction and then wait it out. That's actually what you do. Now, non-FDA approved, some people will use nasal steroids if the baby is struggling badly enough, but that's off-label and it's not FDA approved for babies. Because typically nasal steroids are not approved under age 2, although we use them. So, again, to go over this, a baby cannot breathe through the mouth except when crying. They often get nasal breathers till 3 to 5 months, 3 to 6 months of age, depending on where you read. So that means every baby is going to be a little different, but you have to have it in the back of your mind. And the size of the nasal passage is 2 to 3 millimeters. 2 to 3 millimeters. So think about what 1 millimeter of swelling will do to a nasal airway. They go from 2 millimeters, 1 millimeter of swelling on each side, they have nothing, right? So it doesn't take a lot to tip them over. And that's why our neonatologists are so anal about, wash your hands, don't bring your junk in here, because it doesn't take a lot to tip them over to going from doing okay to really, really struggling. All right, I have some videos, hopefully they'll work. I want you to listen to hear it. Can everyone hear that? Can I stop talking? He's very cute though. All right, so if you were to describe the quality, so does he look comfortable? So what would signs of distress be if he wasn't? Nasal flaring, what else? Grunting, what else? Retractions, right, where all can he retract? That's right, so neck and subcostal retractions. So he obviously looks very comfortable. Now, if you were to describe the quality of his breathing, how would you describe that? If you were talking to me on the phone and you couldn't hold the phone to him, how would you describe it to me? Oh, come on. Just give it a gander. You can't be wrong. I'm just going to say I don't think so, but it's fine. Is it labored? Or is it noisy? Coarse. I heard coarse. Snotty. Upper airway noise. Right. So any version of that. So in my world, I call that sturder. So sometimes a lot of our problems, right, is that when we're talking on the phone and we're speaking different languages, we're all trying to say the same thing, but we're saying different things. So I hear someone will describe that as strider to me. That is not strider because it's very snorty, juicy sounding. Okay? Yeah? So if you said snorty, juicy, I will know exactly what you're talking about. So, but if I wanted to be technical, I'll say that's sturder, and definitely not strider. And I would ask, is the baby having signs of respiratory distress? And odds are you would say no. I would say, is the baby thriving? You would say yes. He looked very healthy. His skin was pink. He didn't look like he was working. So that's not an emergency in my mind. That's one that we can do the conservative things like the saline, the suctioning, and just time, because they probably are going to outgrow it without needing any more intervention than that. Now, the other thing we talked about, so the zebra, which was mentioned here. Any takers? There are arrows pointing to it. Choanal atresia. So this is a zebra we always get called about because everyone has choanal atresia. Everyone doesn't have choanal atresia. It's actually very rare, and we'll talk about this. But basically what you see here, this is obviously a much older patient, so how they've survived, it shows you that not everyone can survive without a nose, but this is an adult patient. These are their sinuses, and this is the back of the nose. And what you can see here is that there's bone or soft tissue that's blocking the back of the nose. That is choanal atresia, and that is obviously one of the most feared things in a baby because they are, again, obligate nasal breathers. So how would we know that? Anyone know the classic findings of choanal atresia? Yes. Can you say that again? Right. So anytime they close their mouth, they turn cyanotic. If they open and cry, they pink out. You feed them, they go cyanotic. If they take out your feeding and they're crying, they're pink. So that's sort of the classic triad. Is that what you see in unilateral choanal atresia? No, because they have one side, and it's not ideal, but oftentimes unilateral choanal atresia is diagnosed much later because you don't routinely pass NG tubes in every child that comes through the nursery. I mean, you shouldn't. If you do, we should talk later. But so this is sort of how babies used to be managed, you know, before a lot of intervention. This is actually a modified McGovern nipple, and what they used to do is that they would actually cut a hole. They would make the nipple sucker big. So it essentially functions as an oral airway, and they'll just tape it to the child or secure it, so that way the child's always able to breathe through the mouth because the tongue is pushed out of the way, the tongue's not prolapsing back. Obviously, the child does not look very happy, and you have no way of feeding the child, but you typically have to have an OG tube or something. So bilateral choanal atresia is one of the few things that we do operate on in the NICU. Like, they wouldn't leave the hospital because it's not sustainable at home, and we would do surgical intervention. So choanal atresia has been known about for a long time. It was first discovered in 1755, and the first operation took nearly a decade to be successful. And typically, the first operation actually used to be done through the mouth, getting into the back of the choana. The incidence is 1 in 7,000, so obviously not very common. Unilaterals are much more common than bilaterals, and for some reason, it's much more common in females than it is in males. We don't really know why. Typically, nowadays, most of us will do endoscopic repairs, which means we use scopes to go in the nose. But again, remember I said a newborn nose is about 2 to 3 millimeters in size. So oftentimes, these kids will also need revision surgery because you're limited just by sheer anatomy as to the opening you can create. The other thing to keep in mind is that just because we create a hole in the back of the nose doesn't mean that the nose will start functioning like a nose. What do I mean by that? So in our nose, we have respiratory epithelium, and the respiratory epithelium beats a certain way. That's why a snot goes a certain way. It's actually directed. When they have choanal atresia, what the research shows is that that respiratory epithelium beats in a different direction. It sends the snot out front. So oftentimes, just because you create an opening in the back doesn't mean the snot is going to go in the back, because the respiratory epithelium hasn't necessarily bonded with your surgery, and it may never. So it's, you know, oftentimes we'll talk about the babies constantly needing saline and just some nasal hygiene to make sure that their noses stay healthy. But they will learn to breathe through their nose, and they will thrive, and they'll be able to leave the hospital. Questions so far? Everyone good? Yep.
The percent that loses nose.
When you do them in the newborns, almost all of them will need some kind of revision surgery. So whether it's just a dilation, whether it's putting some medicine there to prevent scarring, almost all of them will need revision surgery.
That you've seen, is this like a lot of nasal drainage, so you're like, oh, that's a clue, or it's pretty subtle and that's not reliable?
There is a lot of nasal drainage because, exactly right, it has nowhere to go, so it all comes front. We all, like adults, make about 1 liter of snot a day. Now, we don't feel it unless we are like snotty, and then we really feel it. But actually, we make that much, and it just goes back there. We swallow it. We don't really recognize we have it. So for a child who does not necessarily snotty, it has only one place to go, and it's out. So yes, they'll have really disgusting noses. Now, in an older child, it can be a confounder because nasal foreign bodies are more common than choanal atresia. So if they come with a snotty nose, I actually will say, particularly if it's a unilateral snotty nose, in my mind, I'm always nasal foreign body before choanal atresia, but I'll scope them if I don't find a foreign body. All right, so we're going to talk about the oropharynx. So any idea what a issue with the oropharynx is as far as airway goes? What's in the oropharynx? What sort of stuff is in there? Tonsils, right? So what would be a very common issue as far as obstruction goes in the oropharynx? I'm hearing like whispers, but I don't hear you, so just speak up.
The tonsils there, they're swollen.
Right. So if they have swollen tonsils and they're having problems, what is that called? What kind of problems do they have? You're answering a lot of questions. Are you a resident? Can you talk to me?
Yeah.
Okay.
Probably tonsillitis.
So if they have an infection, definitely tonsillitis. But like, let's say they're just swollen and the tonsils are big and the adenoids are big. What are you thinking in your mind? Snoring. Obstructive sleep apnea, right. So that is one of the most common things that we deal with. That is definitely, again, there's all disclaimers, beyond viruses, right? That is our horse. So when they have big tonsils and adenoids, we always think about snoring. The reason why I wanted to talk about that is that at least it seems to me that there is an epidemic of children who are being diagnosed with autism and ADHD. And I will say that in children who have snoring, before treating them with ADHD medication, you need to at least in your mind think to yourself, does this child have sleep apnea? Because unlike adults who have sleep apnea, if we have sleep apnea, we tend to be pretty similar. We're tired, we don't function very well, we get sort of that narcotized kind of thing over a long time. Kids are much more a variety of a spectrum. They can be tired and sleepy and all of that, but they can also be very, very hyper. So, it would be a shame to have a child who has sleep apnea who's then treated with sedative medication to suppress their brain, because that's not the treatment. It's suppressing a symptom, but it's not addressing the issue. So we have another video. Y'all see that? Okay, so what did y'all notice in that video? I mean, if you read the text, then you know what you noticed, but what did you notice, like when you looked at a child? There was retraction, there was sternal retractions, there was snoring. So that is bad OSA. Okay, so when they have big enough tonsils and adenoids, obviously that child is not obese, so that's a different story in and of itself. That's a different problem too. But that child would benefit from getting surgery. Now, in your opinions, is that an emergency, yes or no? How many say yes?
Chronic implications, but nothing really acute.
Yes. So someone said yes. How many say no? Just show a hand.
Urgent.
What's urgent? 7 days, 10 days?
Good question.
Would you admit this patient? Okay, so I will share you my shtick. And listen, we're all physicians and providers here. You can definitely make your own opinion. It's fine. So I would not admit this patient because the nature of sleep apnea is that they wake up. So what is sleep apnea? So a child goes to sleep or a person goes to sleep. The tonsils, in this case adenoids, obstruct. So they fall into their airway. They don't have an airway, so they have the pauses. The brain recognizes that they have a pause, so the brain wakes them up. And then the cycle repeats over and over and over again. Does it need to be addressed? Yes. Is it an emergency? No. Because ultimately the good and the bad of the sleep apnea are the same thing. They will wake up. Parents will come in and say, is my child going to die from this? Over years? Yes, sure. But in a short period of time, months, whatever, probably not, because the nature of it is that the child will wake up. But it does need to be addressed because what are the long-term implications of sleep apnea? Pulmonary hypertension, cardiomyopathy, so some serious consequences. So we don't want them to go there. And sometimes by the time the child presents, they'll already have some of those things. And particularly if they're overweight, you're not going to completely fix them. So they'll need to be monitored. I mean, myself, Dr. Tim, at some pulmonary group, we work together a lot on a lot of these kids because obviously obesity is a national problem and certainly a problem in our area. So pediatric sleep apnea. Typically, it's characterized, we talked about some of these, abnormal breathing during sleep, frequent nighttime awakenings, restless sleep. There are certainly patients that will come that will have some of these that have other things. So if I suspect someone has sleep apnea, what do you think you would do? You can get a sleep study. Anything else? That's good, because that's the gold standard. So, so some people, I've actually had a few patients here who have had home sleep studies done. So that is, the gold standard is an in-hospital sleep study for kids, because there's not really data on home sleep studies. Now, adults can get home sleep studies done. We're not here to talk about adults. I don't, as you all know, I don't like adults. So I'm not going to talk, no offense, I'm not going to talk to you about that. But certainly for kids, it's typically an in-hospital sleep study that needs to be done, because it's done a certain way, and I'm going to show you a few slides about that, and it's read by someone who reads sleep studies, and they give an interpretation. I do not read sleep studies. You have to be typically sleep medicine certified, so I actually rely on my interpretation. I have some idea of what I'm looking at, but I'll tell you why I don't read them in a second. So things to think about are that if they have tonsils and adenoids that are hypertrophic, particularly tonsils, you can't really see the adenoids through the mouth, so you have a sense of what's happening based on symptoms. But look at this laundry list of things. So if they are dysmorphic, if they have a syndrome, if they have sickle cell, if they are obese, sleep apnea just needs to be on your radar with any of these patients, because it's highly prevalent in them. The other thing about this list to think about, and we'll come with the exception of this, is that most of these kids, before we proceed with any kind of management team approach, that first of all, it's usually a team of us that works on them, and they all need a sleep study if you're suspicious of sleep apnea. You don't just like jump in and do surgery. That's just not how we do it. Partly because when they have a lot of other syndromes, there are things going on. They will probably have residual disease. So you want to get a baseline before you do an intervention, because then you don't know if you'll help them or not. The reason why I said not necessarily this is that sleep studies are hard to get in. So if you had to get every child who is otherwise healthy with tonsil and adenoid hypertrophy for a sleep study, I just think we would be at a crisis. So we don't. I don't, at least. Do you? Okay. So I mean, if they're otherwise healthy and have pretty clear history and physical exam, I'll move forward towards surgery and just take them out. But if they're young, my criteria is typically under age 3, and then they have any of these syndromes, I will definitely get a sleep study before I do any management. Because, again, we need to get a baseline, because there's going to be residual disease most of the time. So this is what a sleep study looks like for a child. And this is the other reason why you want to be prudent about knowing what you're sending them for. I actually will apologize to my parents when I'm sending them for a sleep study, because usually this happens and they're like, oh, go to sleep. So how many of you have children here? Okay, so, you know, so this looks awesome, right? It just looks like your child's just going to fall asleep. So they don't, and they spend like most of the night like ripping things off and then sticking back on, and it's just a horrible experience for parents. So what I usually say is that as long as they get some hours of sleep, which they will most of the time, there's no exceptions, we get enough data that we can use that. I try really, really hard not to send them for a repeat sleep study, because can you imagine doing this again? Especially in a small, like 3-year-old or a 2-year-old, it just seems like torture. So we try really hard to use the data that we have to make a decision on what we need to do. This is what the read of a sleep study looks like. And this is why it takes someone with that knowledge to really interpret this. And this is also why it takes time to interpret this, because this is just a blip of some seconds. So they have a whole night to read all of this. So it takes time, and so, you know, you got to give them credit for what they're doing, because they crack out a fair number of sleep studies in most sleep labs, and they have to stare at this. It's all, like, worse than a radiologist's job, I think. I'm like, wow. So what you can see here is that there's multiple obstructive apneas here. There's no airflow that have desaturations, which is the definition of apnea. What is an apnea? Anyone know? Like, if you had to define it. 10 seconds. So for a child, typically 10 seconds. And then, yes, and usually with a desaturation, and then they have arousals, which are the red, which is where the brain's waking them up. And again, within the short time frame, look at how many times this person has the episodes. It's pretty significant. So this will probably be a positive study. Now, for a child, they don't just have to have apneas. They equally can have a hypopnea. So a hypopnea is defined as a pause for less than 10 seconds, but again, can have physiologic relevance. And usually all of that data is put together to create what's called an apnea-hypopnea index. That index is on a scale of 0 to 100. We ideally would like children to be at a 0 or a 1, depending on the literature that you read. So anything higher than that is abnormal, and we at least need to have a dialogue about whether surgery is appropriate, whether medical intervention is appropriate, or what's appropriate for the child. Okay, any questions about the oropharynx?
I presume that they would have to be generally well, no upper respiratory illnesses.
Yes, ideally, because if they go when they're sick, it looks horrible, and then you're not treating the right disease. So just to go back to the oropharynx, what do you think zebras in the oropharynx would be? A web, yep. What else? Growths, right? Tumors, anything like that. So again, each of these things is a topic in and of itself. So honestly, I'm not doing full justice to each section, but for our purposes, I wanted to be pretty broad. So yes, you can have tumors, you can have growths, and any of those things can present with obstruction. And certainly, as you mentioned, viruses. You know, doing a sleep study when someone is acutely sick is a bad idea because you don't know what you're looking at, the data is wrong, and it's completely skewed. So you really got to wait at least like 2 weeks to a month after a viral illness to do a sleep study because that's what you're going to get information about the patient. All right, so going to the larynx. So the larynx is here. Any idea what the horse would be? I heard it, but no one's saying anything loud. It's getting quieter and quieter as I move down the airway. Laryngomalacia. Okay, so what is laryngomalacia? Floppy larynx. So that's literally what it translates to. Floppy larynx, floppy airway. So have a little video. YouTube is awesome. Everyone good? This goes for like 3 minutes though. All right, so how would you describe that quality of breathing? That is stridor. What kind of stridor? Inspiratory stridor. Now, why does that matter? Yes. So now we're kind of getting into a little bit of like the nitty-gritty, right? So that's stridor. I think we all agree that's stridor. Laryngomalacia is typically inspiratory stridor because, as I showed you in an earlier picture, the vocal cords are like a triangle. So you open on inspiration, and in laryngomalacia, they torque on inspiration. So that's why you get turbulence with the torque. So, and that's how they breathe. So I see a lot of laryngomalacia. It is the most common airway anomaly in a newborn. Much more prevalent in preterm babies, but the most common airway anomaly in a newborn. So anyone know what the management of laryngomalacia is? Time. Positioning. What else? Oh gosh, I hope not. Supporting their feeding. Did y'all hear that? So we talked at the beginning about a newborn needing to feed. That is so important. I can't tell you how much. What is that? So what does a newborn, what do babies do? Babies cry, eat, sleep, poop, right? So if a baby has an airway issue, and this actually applies to the whole airway, but certainly applies to laryngomalacia, they can actually burn calories breathing. So there are definitely a wide range of school of thoughts in my specialty as far as what to do. There are centers where if a baby squeaks, they buy surgery. That is not my philosophy, and as you guys go out, you will connect with people who match with your philosophy. So my philosophy is that once I diagnose, so I diagnose them by scoping in the office because I can look at the upper airway in the office, or sometimes here, depending on the situation. I then monitor. I don't scope them every time because really their anatomy is not super relevant unless the anatomy is disconjugate with their findings. Like if I scope them, they're sounding like that, but they don't have laryngomalacia, well, obviously that's a problem, and I need to look for something different. But beyond that, first exam, I always follow their weight. That is the most important thing to me because if the baby is burning so many calories breathing, they will fall off their growth curve. They will not regain sometimes their 2-week weight, and then beyond that, they will just bottom out. Those babies will buy an intervention. They will buy a surgery. And typically, it's not a very complicated surgery. but it certainly can have consequences. And I know Dr. Ruppel and I have managed several of these kids here over the last year doing this. And most of them do well if you pick appropriate candidates, do the appropriate workup, and do the surgery. All we're doing with the surgery is decreasing the floppiness, and I'll show you that in a second. So this is typically what an airway will look like. So epiglottis, anatomically correct, chords, arytenoids. And this is what laryngomalacia view will look like. And what you can see is that there's this very omega-shaped epiglottis, but not only is it omega-shaped, it's just kind of prolapsing, and usually these arytenoids will be floppier too, so everything kind of squishes in every time the baby breathes. So typically what we do with surgery is we'll see these little folds here. We'll release them so that way the epiglottis doesn't fall in as much, and sometimes if there's a lot of redundant mucosa over the arytenoids, we'll sometimes take some of that off. Babies can do really well, but again, you have to do it well. You have to do it with an airway team. I work with a peds anesthesiologist because, you know, babies don't have a lot of reserve, so you're working on their airway as they are breathing, and you can't have a breathing tube in because there's not enough room in a baby to do that. So there's a lot of technical ability that needs to happen, but we've been doing them very well here so far. And then real time, this is what a baby looks like. So this, you can actually see this is some kind of laryngoscope that's holding up the tongue. This is the epiglottis, and see how full and plump these arytenoids are? This is the esophagus here, which, you know, I said I don't really do much with that. But again, you can see everything kind of falls in, you know. So the other thing to think about is that the one thing I watch for most of these kids is that I'll put them often on Zantac, because all babies have sit-up, right? Baby sit-up is normal. They have lower upper esophageal tone. But I don't want a whole bunch of acid on my airway because that can tip a borderline child from being borderline to having edema that they will end up needing surgery. So I want to prevent these kids from needing to go to the OR. So my first realm, if I see a lot of edema over here, is that I'll put them on Zantac and then follow them really closely. And by really closely, I'll use not days. Days is too early. You can't tell anything. Usually it's like a week or two to see that they're starting to inch up their growth curve. Now Zantac, if any of you don't know, tastes horrible. Have any of you tried Zantac? You should try all the meds you give your kids, most of them anyway. It tastes horrible. And so some babies will just gag and spit up from the taste of the Zantac itself. And so sometimes you'll have to give them tricks as to, squirt the Zantac, blow on their eyes, and then make them swallow and do all kinds of things. So, but those are some conservative things that you can try and do. So this is honestly my personal big pet peeve. Laryngomalacia is not tracheomalacia. It is so not tracheomalacia. It's everything but tracheomalacia. So when you call me on the phone, please don't say laryngotracheomalacia, because I just have this moment where I'm like, oh, you know, I don't know what that means, because the diagnosis is different, the treatment is different, the management is different. Tracheomalacia actually means collapse of the trachea. So when you have collapse of the trachea that's dynamic, that needs actually positive pressure. So how do you give positive pressure to someone for a long time? You do CPAP or you do a trach, right? So completely different management algorithm. The other thing is that if they come with rule-out tracheomalacia, I can't look at the trachea in the office. So sometimes I get stuck where I see this kid and I feel then there's been, you know, the parents have been pounded with tracheomalacia, they've done Google MD, and then I'm like, well, I don't think you have tracheomalacia, but the only way I can 100% tell you is I have to take you to the operating room. So, you know, so the lingo, particularly in our society, really matters because everyone Googles everything, and then sometimes we get stuck because they'll say, well, are you sure? Well, I'm not sure you're not going to get run over by a bus, but, you know, but then I kind of get stuck because I'm sort of the end point, and I have to sometimes do an intervention that I don't feel was super necessary. So just remember, laryngomalacia, laryngomalacia. Laryngomalacia until proven otherwise. If you think it's tracheomalacia, still call it laryngomalacia and then send it to me, and then I'll figure it out. So dynamic collapse, most common cause of congenital stridor, and most common congenital lesion of the larynx. So again, squeak baby is laryngomalacia until proven otherwise. Questions so far? So now I'm going to jump around a little bit and talk about a few miscellaneous things. So this is a chart of what a newborn baby's airway size is. So you see that this is a newborn, typically about 3.5 kilograms, and the size of the airway is 3 millimeters. So the reason why this is so important is that when you look at the effect of edema on a baby, this is comparing a newborn airway, a little bigger one actually, 4 millimeters, with an adult airway. So this is what 1 millimeter of airway edema does to an adult and 1 millimeter does to a child, okay? So this is why things like croup and all of those things are so relevant in kids. And this also kind of goes into my kids with laryngomalacia. So the one thing I do tell them is that if your child gets an upper respiratory infection, they might need to come to the hospital and they might need a breathing treatment. They might need racemic epi just to get the edema down, because it can tip them over from doing okay to completely not doing well. And I know some of you at least have seen some of my kids come through the ER that I've sent, because the parent will call me and say, well, they were doing okay, but now they're retracting, they're pulling, they're nasal flaring, and they might have a little bit of a runny nose, they may not. I send them to the ER because there's obviously been an acute change, and the most likely thing is a viral illness, and it's because this can happen, and this can make them really, really not do well. And a few times I've been asked, can they just come see you in the office? And honestly, in my office, do you have breathing treatments in your office? Okay, so I don't. So if they come to the office, I'm going to be like, oh, wow, you look horrible. You should go to the ER. So I don't make them stop in my office to do it, because there's nothing I personally can acutely do in the office, and they really need medical management at that point. But it's a dialogue I'll have with parents. And honestly, for those of us who are parents in the room, you know it's a frightening conversation to have. When I'm saying this is what your child has, they're probably going to do okay, but if this happens, this is what your plan needs to be. We talked a little bit about the spectrum of treatment of laryngomalacia. So again, for them to go to surgery, they have to not thrive. And different centers do it differently. But that's my shtick for them needing to go to surgery. And by not thrive, not gain weight, and not be feeding effectively. So, okay. So when you're seeing a child, what is your algorithm of looking at the child? How do you know that a child is looking good versus a child is not looking good?
Are they conscious?
That's helpful, yeah.
Talk about, like, how they look, how are they sitting, do they look cyanotic?
Right. So if they tell you someone's in respiratory distress and you go in the ER and they're like laying on their back and looking okay, what's your thought? Is that respiratory distress? No, right. So, but sitting up and actually sometimes leaning forward, sometimes those are some subtle signs that you need to think about. You know, why is this child sitting up, leaning forward? Is that their comfort? Are they trying to hold something open? So there's lots of things we want to think about generally. So we want to look at the overall appearance. You know, some of those syndromic kids can have really challenging airways. So if they have a really small jaw, we have a fair number of Pierre Robin kids come here. Anyone know what Pierre Robin is? Why is it relevant? Is it a syndrome or a sequence? It's a sequence. What's the sequence? Small jaw. Is it a large tongue? Why is it protruding? Right. So it's actually typically not necessarily a large tongue. It's that the jaw is small. So when the jaw is small, the tongue doesn't have anywhere to sit. So the tongue is too big for that mouth, and so the tongue goes up. And when the tongue goes up, the maxilla heals by two shelves coming together. The tongue's in the way, so they have a wide U-shaped cleft. That is the sequence of Pierre Robin. But also, when they have that big tongue, the tongue tends to fall back and will obstruct them. And that's why Pierre Robin kids have a lot of airway obstruction. So, but from our standpoint, they can also be incredibly hard to intubate because they have that small jaw, so there's not a lot of wiggle room when you're trying to intubate them, and that can create a real challenge for you. So if they're holding their head out here, sometimes that can be a sign that something's going on because it is not a natural position to kind of hold your head out there. And then if they have, masses or lumps, and if they've had a history of anesthesia problems, those are all things that you want to keep in the back of your mind. So if you were to march down your tree, you have a child who is in some respiratory distress. What is your ladder? Like, you assess them. You've determined that they need some kind of intervention. How do you march down your intervention tree? You call for help? You should call for help. Okay. What's that? So let's just say they're getting there. They look not good. How do you determine that?
Basically by how their work breathing is appearing, how anesthesia looking?
So let's say they're looking a little bit like they're working and they're starting to look a little tired. What would be your first intervention potentially? Positioning. Right. So you position them. You optimize the position. I always say at this point, whenever you see a child who's, or any patient who's having any airway things, always think to your mind, you know, the algorithm you want to go through and have a suction handy. Because if they barf on you, they barf in their airway, and that's bad, right? So suction, 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 in all of this suction. Okay, so positioning, then what? So positioning helps a little, but they're still working, then what? Oxygen, then what? This is like a read my mind kind of question. Okay, so absolutely. So the first thing, after you do your general assessment and determine that this patient needs help, you want to position them appropriately to optimize them. And typically, if you're positioning them, you want to sometimes pull up the jaw, which kind of gives their tongue more room, can relieve some obstruction. You want to clear away suction, secretion, suction, suction, suction. I really emphasize suction. A mask airway is your friend. So for this room, you know, the gold standard of airway management, typically everyone talks about intubation, and that is true because you have control of the airway, you protect the airway against secretions. But you need to have an algorithm on how to get there. You also need to think to yourself, what if you can't intubate the patient? What is your fail-safe while you call for help? A mask airway will save a life, and that's really important. Like when you guys spend time down with anesthesia, know how to mask your patients. It might seem very redundant, but if you can mask a difficult airway and just keep the airflow moving until help arrives, you will save a life time and time again. And just call for help. You know, if that's where you end up, call for help, mask the patient. There are so many times on the phone, I'm like, stop instrumenting the patient, I'm coming, just mask them. If you can mask them, mask them. Sometimes you can't, and then you'll have to go down your tree, but if you can mask them and you're not sure what to do, that's a good way to stop. So you'll sometimes do an oral airway or nasal airway. You need to be careful with oral airways in kids. Again, if they're really little, remember their larynx is right there, so you can tip them to laryngospasm. And if you're taking care of someone who has an upper respiratory infection, so you want to make sure that you're also putting it in so you're not pushing the tongue back. I see that a lot of the times where the oral airways are shoved in and the tongue shoves back with it. Well, you're not doing anything with that oral airway. Nasal airways are used much more in older people, teenagers as well as adults. Does anyone know what an LMA is? Yeah? So it's exactly what it says. So it's basically a mask, but it's for the larynx. It actually is positioned in a way that it just sits on the larynx. Now, same as any mask, it does not protect the airway against secretions, but it's a handy tool for some of our difficult kids that you can't necessarily get a tube in right away. You can stabilize them by putting an LMA in and just give them, again, give them positive pressure and kind of get things in order. Intubation, everyone has a type of blade that they love. I'll show you a few pictures of these two. I don't have a preference as to a type, well, I have a preference, obviously, I'm a surgeon. But I don't have a preference as to what your preference needs to be. Your preference just needs to be whatever is most comfortable for you and whatever keeps the patient safe. I personally like Miller blades for almost everything, and that's partly because my laryngoscopes that I use in the OR are all shaped like Miller blades. So it's my comfort zone and it's where I live. But a MAC is perfectly fine if you know how to use it. And then finally, a surgical airway. I'm running short on time. Okay. So I'm going to just pump through a few of these slides so we can get to a couple of things. So positioning is really important because what you're doing is you're avoiding constriction and you're avoiding pressure. You want to like optimize your external forces. There are different kinds of oral and nasal airways, and they come in lots of different sizes. And yes, they are sizes enough to fit our newborns. So those are always good things to use. You'll often see when you're with anesthesia, you'll see them, measuring out on the outside before they put it in, and that's just because they want to have a good idea of where that tip ends up so it's not affecting. And even that, they're still gray. Sometimes you'll put it in and you'll see the person do like the gag thing. Well, it's too far down, so you might need to drop their size. A mask. I can't tell you enough how much this will help you. So when you're in distress, not you personally, but when your patient's in distress and you're in distress with your patient, you can mask them and you can call for help and it'll save a life. And these are what LMAs look like, and this is essentially what it does. So it's put in through the mouth and it just sits over that larynx, but it has to have a nice seal for your positive pressure to go in or your air will escape all around it. It also, just like an endotracheal tube, has that cuff thing, so you can put some air in the cuff around it to get that seal. Miller blades, Mac blades, your preference is whatever you're good at. And then finally, a trach. So I'm going to talk a little bit about trachs today. We try really, 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 really hard not to do emergent trachs in kids. In fact, we try hard not to do emergent trachs in anyone under age 12 because you can totally transect their trachea if you're rushing to do something. So most of these, there's a lot of conversations happening around these kids' airway management, and what we try to do is try to bring them to the OR in a controlled environment with a team, and we try not to rush anything. Because when you do a trach, there's an element of force, and there's obviously a lot of speed associated with it. And when you cut into the trachea and you put too much pressure in a child, you will completely separate their trachea, and you will kill them. So the same person you're trying to save, you're not going to do a good job on. So that's why there's a lot of conversations that happen to make sure that we can do it in a controlled way to keep the kids safe. But ultimately, a trach is for certain kids. I mean, we have one in the NICU that we're going to do shortly. But basically, what you're trying to do is you're trying to get a surgical airway. The other thing I want to point out is when you do a trach, for most patients, this is still patent. For kids in particular, yeah, their kids you're doing it for a difficult airway, and their kids you're doing it for other reasons. So for most kids is that they have chronic pulmonary disease, they have a declining airway, you can't get them off the vent. Those are the most common reasons why we'll do a trach. So this is functional. So when you're doing your troubleshooting of a trach, don't forget to go back to the basics. You know, if this is not working, you can still go up here and mask a patient. Plug the hole, mask a patient. Take it out, mask the patient, if that's what you need to do, again, if this is not working. And you always want to kind of go back to the basics and keep the mask airway in your algorithm. This is a whole new world, but I just thought I would introduce it to you. So when you start talking trachs, there's a whole different language. There are several trach companies. Here we use two. We use the Bavona and we use the Shiley. The Shiley is cheaper, the Bavona is more expensive. I like the Bavona, not just because I like more expensive things, but because I think it gives my patients more options. Trachs can be cuffed or uncuffed. We use both. If they need to be on the vent, they typically have to be a cuffed trach because you need a seal so that pressure can go down the right way. Also, the things to think about are that most baby trachs are just one lumen. Adult trachs will have something called an inner cannula, so it means that their trachs don't have to be changed out as often. They can just take the inner cannula out and clean it. PD trachs, it's not that, oh, I think it's gross too, but anyway, whatever. But PD trachs, you know, it's the whole thing has to come in and come out. So when they get crusted or occluded, it's the whole trach that sometimes has to come out if it's a well-established trach, and we'll come to that in a second. So just to show you some stuff, this is a flange that goes on the neck. When a fresh trach, this is often sutured to the skin. Nothing that we do to a fresh trach is foolproof from getting a trach in a false tract. So there are all these belts and suspenders that we do to try to keep our patients safe. And that's because when you first put a trach in, it's an open wound. It's an open wound going from the neck all the way down to the trachea. And we leave it alone for about 7 to 10 days, depending on your style, because we're trying to get a tract that is nice and epithelialized so that they have a safe trach. After 7 days, usually that tract is well formed, and then we do trach changes, teach the family to do things and whatnot. But before, if that trach comes out, the trach tube can go anywhere because all of the tissue in kids is soft, right? So if you're trying to ram it in something and there's not a well-established tract, it will go somewhere where it shouldn't, and kids can run into trouble. And then usually when we put a trach in for the first time, there's an obturator that goes in, which is almost like the Seldinger technique that we all hear about. It leads you to the path of least resistance. And so you put it in, take it out, and then the vent or oxygen or whatever you need. Trachs come in many, many different sizes. Sometimes in the NICU, why we wait on babies to trach them is because the babies are too small. The smallest size trach is about a 2.5 trach. I try really hard never to put that in because you don't have any troubleshooting mechanism. There's almost no suctions that go through. It just creates sort of a mess. So for some of those kids, we'll just wait for them to grow big enough that we can trach them. But 3.0 is pretty typical. And so a 3.0 trach tube, the outer size is 4.3 millimeters, and the length is pretty short, you know. All you can see here is the lengths are short. And the reason why I'm putting that in is that it doesn't take a lot for a trach to be in or out. And I'm running over, so I'm sorry. But, okay, I'm going to skip these because we've kind of talked about this. So a difficult airway is one that can't be maintained well, in my opinion. And so you can't maintain it by mask. You can't maintain their O2 sats, and it's taken a trained anesthesiologist more than 3 attempts or more than 10 minutes to intubate them. By definition, that's a difficult airway. Now, we're careful about that, and we have peds anesthesia here who's very good, so we're able to minimize some of this. You'll see that in places where they don't have peds anesthesia, people get labeled with difficult airways all the time that are not correct. It's just inexperienced anesthesia. So the value of that peds anesthesia, I can't say that enough. So a failed airway is someone who you can't intubate or you can't oxygenate. That's a failed airway. And so, again, as you're running through the team, especially when you're down with anesthesia, you think about the steps that we talked about. And you'll see the anesthesiologist will march through those steps as things are happening. They will call for help all the time. Talk about suctioning. So fiber optic scopes. None of these skills are particularly easy. The anesthesiologists do them all the time. But a fiber optic scope basically lets you scope a patient with an ET tube on it. So if you're not able to get a tube in the traditional way, or they have a difficult way like a Pierre Robin and things like that, this gives you some ways of seeing without putting a blade in and trying to get that tube in. But usually it's a team approach. And this is something called a glide scope, which is what you can see is that this scope looks like a sort of a Mac blade, but has a camera on it, and they're actually looking over here. And then when they're looking over here, they're putting a tube. But again, it's a different skill set, because typically when you intubate a patient, you're used to kind of doing this and putting a tube in. But when you're using a glide scope, you're doing this, but you're looking over there and putting a tube in. So again, you know, it's a skill set that not everyone has. And if you've never used a glide scope on a difficult case, please don't start, because you will not do well. So we talked about surgical airways, and the only thing to mention here is that if they're under 12 years of age, rather than doing a slash trach, as everyone's so fond of calling, we typically will do a needle, because you can get positive pressure with a needle and maintain an airway until they can get down to the OR to a safe, controlled environment, as opposed to slamming a trach into a patient. So trach troubleshooting, the biggest thing to know here is that if the trach is mature, meaning it's been in for more than 7 days, or immature, meaning it's been in for less than 7 days, because that changes your algorithm. If it's been in for more than 7 days, if a trach gets plugged, you can take it out and put a fresh trach in, and you'll see our respiratory therapists do that all the time, because they get, especially for PD trach, they're so small, they get crusted and gunky really quickly. If it's, however, immature, they'll usually try suctioning really aggressively and doing those things, because if you take it out, you might burn bridges, because everything can collapse on you, and you might have to end up intubating the patient. Now, is that a terrible thing if you save their lives? No, but it's just to keep in mind that you may not necessarily be able to put a fresh trach right back in, because it's not a mature stoma. And again, emphasis on the above is always an option and open to you most of the time, because most of our patients don't have laryngectomy. Okay, so a couple more miscellaneous things. Anyone know what is here, or what I'm talking about? This is a zebra. You're not allowed to talk, because you know. Any clues? Yeah, so this is an MRI, this is a 3D ultrasound, and this is a traditional ultrasound. And what you see is what looks like two heads, right? A face with something that's not right, not right, not right, and not right. So anyone know what an exit procedure is besides Dr. Collins, because I know you know? Okay, so an exit procedure is honestly a huge cluster, but we do them. Because some babies need them, because if they have a prenatal ultrasound and you see one of these, this baby, you have to be prepared that when they come out, if they have a giant thing on their face, that they're not going to be able to breathe well, right? Does that make sense, right? You have a giant thing on your face, you can't breathe well. So what we do is we then use, it's a team approach. It's usually OBs, maternal fetal specialists, feed surge, us, me, neonatologists, OR nurses, anesthesia, the whole kit and caboodle are in there. And what we use is that we get a baby delivered by planned C-section. This does not go into spontaneous labor. And when they're by planned, do I need to wrap up? I do, guys. Okay, when they're by planned C-section, they're still connected to the placenta. So the baby is literally on a Mayo or some kind of thing connected to mom. That gives you about 2 minutes of time where they have placental oxygen flowing and you establish an airway. So obviously that's one of the few situations where we do emergent airways. but it's a team approach, and we're all there. And usually we do some dry runs before, so when the baby is actually born, we're not staying there. I'll tell you a quick funny story. When I was at WashU, we did an exit procedure, and the baby was born, and the OB cut the cord. And we were all like, what? But we got the airway in, but we cursed out the OB. But anyway, this is what it looks like. It literally is a cluster because we're all in one OB suite. And anyway, so things happen. So to wrap it up, neonatal obligate nasal breather, poor breathing, poor feeding. Viruses cause inflammation similar to structural issues. When in trouble, be methodical, ask for help, and go back to your basics. And that's all I have.
I think we are over time, so if you're on the phone, sorry, we ran out of time to unmute them, but you can always email us at outreach@carillionclinic.org, and I can get them to Dr. Jeyakumar. With that, we're going to go ahead and disconnect the phone lines now. Thank you all very much for joining us.